You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract. We have a special episode this week with Doctors Carla Marienfeld, Marcela Smid, Tanner Wright, and Ljuba Mirsky, who discuss the emerging concept of fetal fentanyl syndrome. We hope you enjoy the episode.
Hi, everyone. My name's Carla Marienfeld. I'm an addiction psychiatrist and clinical professor of psychiatry at the University of California, San Diego. I'm very excited to have this talk today about these two articles that are that have been published in the Journal of Addiction Medicine. The first article that we'll be discussing is by Dorsey et al., a large group of researchers, including one of our Journal of Addiction Medicine supporting editors, Marcela Smid, who will be joining us as well today, as well as Tanner Wright, who's going to be talking with us. And so the first article that we're going to be talking about is a little bit different. It's interesting because it used a very large multi-site surveillance database. So it had over 5,000 mother-infant pairs that were affected by opioid use disorder. And they looked at certain physical features like microcephaly, cleft palate, foot deformities, things that have been reported as potentially being part of something that's sort of colloquially known as fetal fentanyl syndrome. And we're able to look at this very large sort of population level view of this. And it showed some of the key takeaways that while they did see some of these features were somewhat more common in the fentanyl exposed infants, individually, each of these features was rare and they almost never appeared as a clustering like what's been described with the fetal fentanyl syndrome. The second article we're going to be talking by Mirsky et al. Is about prenatal fentanyl exposure association with characteristic neonatal anomalies, and really takes that sort of ground view, looking at individual patients, not this sort of large de-identified database, but really looking at a case series from a single Kentucky institution where they screened nearly 640 pregnant women over a long period of time who were enrolled in a substance use treatment program. And they found 4 neonates whose features, including the small head and cleft palate, appeared somewhat consistent with the proposed fetal fentanyl syndrome that has been proposed out there. And so you get these two different perspectives. The key takeaway from that paper was really that these cases added to a growing body of some evidence or case series, a number of people, babies that have been identified. But the authors there also report on the importance of being sort of cautious and over-interpreting these findings and really trying to separate out some of the other exposures as well as what's going on in this case series and how important that is for us. So that's a sort of broad overview of the two papers, and we've got some really interesting questions to get into. Before that, I'm going to ask, I think I'll go ahead and ask Dr. Smid if you would introduce yourself, and then we can ask each of our authors here today to introduce themselves.
Hi, I'm Marcela Smid. I'm an associate professor at the University of Utah. I'm a maternal fetal medicine and addiction medicine specialist and a supporting editor at the Journal of Addiction Medicine and a co-author on the Dorsey et al. Paper and editor on the Mirsky et al. Paper.
And then I'm Ljuba Mirsky. I'm a maternal fetal medicine fellow, finishing up fellowship at the University of Kentucky, actually here in about 2 weeks. I did my OBGYN residency training at University of Tennessee, Knoxville, but otherwise have been at the University of Kentucky for the majority of my training, including undergraduate and medical school. And I've had the privilege and have been able to develop a passion for caring for the substance use patient population at our Pathways Clinic here at the University of Kentucky, which is an excellent multidisciplinary treatment program that we have, and I'll be excited to talk a little bit more about as we discuss my paper. I'm happy to be here today.
Awesome. We're excited to have you. And Tanner Wright?
I am Tanner Wright. I'm associate professor at University of South Florida, Morsani College of Medicine in Tampa, Florida. I am a pediatrician and addiction medicine provider here in Tampa at one of our PRISM PD partner clinics, where we are co-located integrated care model for families that are impacted by substance use.
Wonderful. Well, thank you three for joining today. I wanted to talk first about kind of one theme around navigating the stigma, language, and some of the risks of harm that might be associated with some of the findings in your work. So, starting with you, Tanner, the Dorsey paper, your study explicitly notes that attributing fentanyl as a cause for the observed features has real-world consequences for mothers, including stigma and punitive legal actions. Yet, the study did find a statistically significant correlation. There were some infants with at least one feature of interest, and those that had at least one feature of interest were more likely to have a documented prenatal fentanyl exposure. So my question to you, and then I'd like to open it up to the group, really is, how do you balance the scientific imperative that we have to, report associations that we find with some of the ethical responsibility to ensure that these data aren't weaponized by media, used by policymakers to justify punitive measures like, custody removal, criminal prosecution, for a highly vulnerable population when we know that, they're more likely to benefit from treatment instead?
I think you're starting me off with probably the most important piece of all this work. I think if you were to talk to colleagues and co-authors on the paper and stuff like that, this is probably where most of the discussion actually happened. And as we were kind of putting together this analysis and this manuscript, the importance of how the presentation looks, right, and how we're going about this. Because I think that in all types of exposures research, perinatal substance use work, we know that it requires kind of careful and nuanced research just because the implications are significant. And how we interpret these findings around perinatal substance use, it can influence stigma, it can influence policy, access to care, engagement with services. So it's important that we don't draw premature conclusions with that. And I think historically, we probably all can agree upon the idea that we haven't been the best stewards of patients' respect and trust, I think, when we look at the history of substance use and how the healthcare system kind of provided services to them. And so I think that it's incredibly imperative to focus our approach to this emerging topic very carefully with a lens to ensure that what we're doing is in a way of being trauma-informed, anti-stigma, patient-centered, just because I do think, this is the start of a lot of research that's going to come out, right? We know that this is an emerging topic. We know that with the changing landscape of substance use, there's a lot of things that will come with new exposures that we see in pregnancy, and if there's further implications of those exposures themselves. So while the dissemination of science is important, the way that we do it and the approach that we take is probably even more important.
Absolutely. I think that was really well said. And turning to you, Ljuba, when you think about this idea of this fetal fentanyl syndrome, is it a proposed thing, a possible thing, a probable thing? Your paper actually uses the term fetal fentanyl syndrome a little bit more directly than the other one. And you noted that 7.8% of your cohort with self-reported fentanyl use had neonates with at least, one or more signs of consistent with what's been described as this fetal fentanyl syndrome. So the question I have for you is that, there wasn't necessarily the same outcome. The Dorsey paper didn't really find a constellation of things. In their paper, it was really just one finding, whereas yours and some of the original series, the Wadman series and the Martin Rodriguez 23 cases, where you actually saw some clustering of a few symptoms. So how do you kind of reconcile these findings, and what additional evidence do you think would be needed to think about whether we shift our thinking from something that's just proposed to more possible?
Yeah, and in our paper, we definitely did use the term fetal fentanyl syndrome, I think, a little more directly, partially in an effort to summarize our findings and kind of make them easier to reference. But we totally agree the syndrome we're discussing is indeed proposed at this time. It's not validated by any means. We basically aim to discover a constellation of findings in our study population when we set out with our case series. And that's why we only included neonates with small head circumference and an additional anomaly or multiple additional anomalies, because we were trying to replicate the Wadman findings as best as possible. But as you mentioned, the Dorsey paper found that the majority were single anomalies in neonates. So it definitely makes it difficult to reconcile these findings, as I think is often the case with early studies of a proposed kind of somewhat rare syndrome or phenomena. I think additional evidence, which would be non-disputable and could help kind of shift this syndrome from proposed to probable, would be things like basic science research that looks further into the pathophysiologic mechanism of fentanyl's effect on cholesterol metabolism, as well as additional animal model studies, which have been started to kind of further validate the syndrome. And then finally, also just additional studies kind of similar to these two, increasing the numbers and just kind of strengthening the association through numbers.
Yeah, I think that those are really good points. And if we have time, I'd like to talk a little bit more about explicitly what you brought up. And in fact, let's maybe go there now, since it came up, because I do think it's really interesting to think about what do we need to really further these things along. And it's not just these clustering of things, but having this biological, plausible biological mechanism. Some of the in vitro data, so some work by Corradi et al., showed that fentanyl disrupts the post-lanosterol cholesterol biosynthesis. But some of the historic animal models that actually used more sort of pharmaceutical grade fentanyl that wasn't necessarily combined with anything else didn't show these classic the teratogenic effects. And so I think it's interesting to think about, for both of you guys, what do you think about this disconnect between the proposed mechanism and some of the findings, but then some of the animal studies not supporting it? And how does that fit in with your understanding based on the findings from your work, and the fact that in both of your studies, there was a lot of polysubstance exposure, and that we don't know necessarily what adulterants, polysubstance exposures, novel fentanyl, substrates, different cutting agents and things like that might, have on all of this.
Yeah, I agree. At this point in time, it's definitely difficult to ascertain whether some of these adulterants or cutting agents may be the ingredient that's actually responsible for the proposed teratogenicity that we're proposing for fentanyl. I think, once again, additional studies that maybe attempt to single these out would be helpful to elucidate whether fentanyl is the true teratogen. But I do think there's probably also a component of the high dosing that comes with illicit use, rather than, maybe prescribed pharmaceutical grade fentanyl, that may be critical to the teratogenicity that we're seeing as well.
As well as the underlying sort of vulnerabilities that somebody might have to it.
Yeah, I think the reason why it's such a cool discussion is because I think we're really just scratching the surface. And I think that if we go back and listen to this episode in like 5-10 years, it's gonna be like, wow, we know a lot more than what we did back then, which I think is fascinating. So I think it's very cool to be involved at this point in time with this discussion. I think there's so many things that can influence how we see some of these differences in babies. And so I think that this is a great juxtaposition of like how the two papers are two different approaches to help add to what is the body of science that we're receiving in regards to this topic. Things that we know, there's variable phenotypes in many of the exposures research or in teratogen studies. And so the idea that we haven't been able to nail down kind of a dose-dependent relationship, a timing, variability in the phenotype, it does lend to us the ability to think about other contributors to why we would not have this like direct, simple proportion of what we would expect to see based on the exposure itself. So I think that, like Ljuba was talking about, that the dose is an important thing, the adulterants are an important thing. I think some of this, the mystery of some genetic predisposure to some of these phenotypic differences, I think is what we will probably uncover at some point in the future that we don't exactly know right now. So I think there's a number of different things, because there's plenty of pregnancies, and this is again in all types of exposure research, where you feel like you should see the outcome, you should see the teratogenetic effects, you should see the infants with differences, and you don't. And the question is why or how. And I think that some of that's still to be discovered. And I think that's why continued research in this area is really important, because there's a lot to be answered about the differences in what we see.
I think that's a great point, like a kind of a two-hit theory, which is a little bit what the karate paper also was showing. I think it'd be really interesting, like you said, to look back and see there probably is a population that is more vulnerable and more predisposed in combination with fentanyl exposure.
Mm-hmm. Well, and it also brings up, like you're saying, potentially underlying genetic vulnerabilities, but also polysubstance exposure as well. And the fact that, in both of your papers, there was quite a bit of other substance exposure that, in addition to what we don't know about illicit substances, but known things, tobacco was in there. And for many of the participants, I think all of the participants, if I remember correctly from your paper, Ljuba, had tobacco exposure, et cetera. And in addition to the numbers of exposures, the other thing that I think is interesting while we're on the topic of kind of the biological plausibility is where you sometimes see some clustering of some symptoms, and sometimes you really only see one or two paired together. And how do you think about that in terms of where does that fit in our understanding of a syndrome that might be quite variable or different?
I think it goes right along the lines of it potentially being more of a spectrum than a syndrome, since we are seeing such a variable phenotype. I think this is a good point or a good area to kind of bring up, that it's a question of whether this variable phenotype strengthens or weakens the assumption that we have at this point that fentanyl may be causal in this syndrome, because at the same time we're seeing a variable phenotype, but despite kind of polysubstance exposure, we are still seeing a somewhat similar phenotype when you think about it that way. It's kind of, like I said, I think best probably described as what's going to be a spectrum. And we've been using fetal fentanyl syndrome kind of experimentally, and it's of course still just proposed. But I think as we start to further elucidate the findings and the patterns, it's probably going to be more of a spectrum, and that would be the more accurate way to describe it, I think, clinically.
Yeah, I'll just add from the approach in our paper, us utilizing like a surveillance network of maternal infant dyads that have OUD, and analysis and looking at MOUD utilization and stuff like that. From my perspective, when we look at our analysis, again, we're looking at utilizing the surveillance network that's based on the EMR and based on coding, based on diagnosis and stuff like that. So when we see some of that clustering, or we see certain findings but not other findings, you also think of from the perspective of how we are looking at the large number of dyads that we're looking at. And you think about, okay, the clinical application of some of these things. So a good example is some of the findings that we're looking for, one being cleft palate, another being micronathia. I'd put a bigger bet on a clinician including cleft palate in the coding and diagnosis than I would on the confidence in every single time capturing micronathia when it's there. Do you know what I mean? So it's like one of those things too, that as we look at some of these things, a lot of these findings are quote unquote soft features of different genetic conditions. And so a lot of times I think as providers, you may not always capture that within the EMR. But then when we look at specific individuals or patients where we're looking for a diagnosis, for sure you're going to really look to see, do I have a single palmar crease? My toes, is there any type of syndactyly? Is there even the smallest bit of syndactyly? So that's where I think that the approach is a little bit different. And so when we see some of the clustering from our analysis, may just be a pattern seen when we do some of this surveillance network type analyses, when we're leaning heavily upon EMR.
Well said. And I think that's what's so valuable about the timing of, publishing your two papers together, because there really are strengths and weaknesses in both approaches, and they complement each other quite a bit. And you really speak well to the value of having these smaller case series where you can actually check with a fine-tooth comb that just really gets lost in these big EMR, data sets where you're really reliant on somebody else's ideas of what they're looking for and what they're capturing. And so that really is important to have both of these contribute to the conversation.
So I was going to add. So it's important to remember that it took decades for alcohol of really careful work for alcohol to be established as a teratogen. Because even exposure isn't always going to lead to the syndrome, even in alcohol. And we see that to Dr. Mirsky's point, right? We have a spectrum, we expect a spectrum in alcohol. And that took decades of careful research. So I think it's important for us to, is fentanyl a real teratogen? Unclear. Maybe it has some of the features of establishing human teratogenicity, but we are not in a place where we can really control for confounding factors. We'd have some biological plausibility with the preclinical data, with Karate's data. But I think we're still in a place where we need exactly what's happening is people to be looking at their own data. So surveillance networks are great, but for example, MatLink is a surveillance network that's based on the EMR. Codes are used for billing. They are not used for establishing teratogenicity. So when we think about doing that research part, right, that's the code for billing has been established for complexity. Once you've got something in there, Dr. Mirsky's team are able to really look at the features of that kiddo. And so this is really a plea to people who are interested, who are listening to this and interested, that the only way that this gets established is if we're talking to each other and really pooling our data and saying, what are you seeing in your data? What are we seeing in our data? Because if it's a true teratogen, fentanyl itself, we should be seeing it all across the country. If it's something else, maybe it starts to cluster in different places. If there is a genetic predisposition, perhaps there are populations that are more likely to have that genetic disposition. So we really need people to be reporting what they're seeing in their data in a way that's capturable. So this is a plea to those listening to this podcast. Your data is important. If you are seeing patterns, this is why case reports and case series are part of the medical literature. This is how we talk to each other and are really able to communicate. Are we seeing a new or novel thing that is important clinically for us to understand so that we can better take care of these dyads, as we've certainly seen in alcohol and fetal alcohol spectrum disorder. Understanding it has lifelong implications for these dyads.
And I think that plea is so important because it also changes the scene from prospective to retrospective. For example, as Tanner mentioned, in our study, even though we did look into individual charts, and I personally did the chart review, the exams that were being performed were not dysmorphology exams. And so it needed to be a finding that was pretty significant for the NICU team or the pediatrics team to report the finding. And so if we are now on the lookout and can prospectively be doing, more of a dysmorphology exam, I think that the findings would be super interesting and important to further developing this potential teratogenicity.
So you brought up a really great point, Dr. Smid, Marcela, about the fetal alcohol spectrum disorders and how that is an interesting model, both in understanding the timeline in terms of, wanting to have an answer right now and needing the time and space to really do the science and understand it. But we do have a interesting parallel in fetal alcohol spectrum disorders. And if validated, potentially this so-called fetal fentanyl syndrome could be recognized as a teratogenic syndrome tied to something that somebody uses, a substance, right? And so I'm just curious for both of you, if you look back at this scientific and the societal history of the fetal alcohol syndrome, which triggered a lot of public stigma, uneven sort of legal crackdowns, what were some of the systemic mistakes that our medical and public health communities could avoid and learn from this history as we go forward?
Yeah, I think the emphasis, unfortunately, when fetal alcohol spectrum disorders was discovered, was more one of kind of moral blame rather than talking about how do we prevent or treat this. And I know it was framed as more of an issue of willpower rather than a true substance use disorder medical problem. And so this stigma forced birthing parents to hide the diagnosis. The legal system came in with punishment rather than support and continued to kind of ignore this need for treatment, unfortunately, for quite some time, which victimized a very vulnerable population. And so I think as we move forward with investigating our fetal fentanyl syndrome, we have to emphasize addiction treatment and reducing that stigma, as well as compassionate counseling. And the things that we really need to avoid would be confusing association with causation, which I think is what we've been talking about today, is we're all being very cautious to assign that causal connection. We have to avoid victimizing our birthing parents, and then also avoid marginalizing specific groups to kind of do this, quote, the right way.
I think if we were to develop a poll of all healthcare providers who care for pregnant individuals that have some kind of substance use, who may be the exact individuals that would be at risk for having an infant born with some differences secondary to an exposure, in this poll asking, how do we actually improve outcomes? So with like FASD, how do we actually decrease the incidence? How do we actually improve our childhood outcomes and stuff like that? I think across the board, you would get a lot of respondents that would talk about treatment, accessing care early in pregnancy, improving the counseling, improving the management of the substance use disorder early in pregnancy to potentially prevent the diagnosis from being there, or the exposure, enough of an exposure to put the infant at risk. So I think I'd probably get a lot of heads turning when it's the pediatrician saying focus more on the pregnancy than on the child. But I think that we all agree, right? So I think if you truly said, how do we affect change, improve outcomes in regards to FASD, and then insert any other exposure where we'd ever have a concern now or in the future, how do we do it? It's how do we decrease the exposure? How do we appropriately manage the underlying diagnosis or condition? So I think that regardless, the number one objective, the number one priority, I guess number 1, 2, 3, 4, 5 priority would be treatment, right? Would be accessibility to good treatment, accessibility to trauma-informed care, anti-stigma initiatives, like things that we know will actually improve addiction care during pregnancy will 100% serve your ultimate goal of decreasing the incidence and improving your outcomes long term. So I think that every single thing that we do, whether it's in research publication, whether it's in developing clinical service, whether it's in public health initiatives, the first thing we should do is this serving the primary goal of appropriate treatment and management in pregnancy to ultimately move the needle and truly impact the outcome?
Yeah, I think whether or not fetal fentanyl syndrome exists or not, we have already existing mountains and mountains of data about the benefits of medications for opioid use disorder. And if this adds anything to that, it's the importance of having these on board before someone becomes pregnant. I think Dr. Mirsky, you're one of the major strengths of your case series is that there is a temporal association with whatever may be going on here. All 4 of the affected infants had maternal fentanyl exposure during the first trimester, right? When we know there's organogenesis, we know there's embryonic cholesterol biosynthesis, some of these, proposed mechanisms going on. And so I think the idea of medications not just started when somebody finds out that they're pregnant, but really trying to prevent the use of fentanyl for many, many reasons in, potentially people of reproductive potential is critical there. So how do we then get that message that Dr. Wright, you so clearly articulated out into these public health conversations, into groups around reproductive health and family planning, as well as addiction, as well as other populations? How do we really do that? Yeah.
And I thought that was a great transition and an excellent point. Typically preventing and treating during pregnancy is the emphasis, but I couldn't agree more. I'm glad that you kind of point that out from our conclusions of our study, is that it's seeming like the best time to act is going to be preconception, which is such a challenging time period, both with individuals with substance use and without. Oftentimes we have not gotten to have that sort of preconception conversation we would have loved to have with a patient with any particular medical disorder. And so it really is very challenging, but we truly think the preconception window is going to be such an important window for intervention. The first trimester, as you mentioned, is going to be that most pivotal time for the development of various different issues that we can expect in pregnancy. And so to answer your question about, how do we shift that conversation, couldn't agree more that it needs to start preconception rather than after the first trimester when all of this has happened. And for individuals of childbearing age with opioid use disorder, I think reproductive health is going to have to be built into kind of routine addiction care. And so that's going to include things like access to contraception, pre-pregnancy basics such as prenatal vitamins and folic acid, infectious disease screening, mental health care, which is usually so intimately tied to substance use, as well as, many other important preconception areas of discussion. And the challenging is going to be that funding for this sort of care, I think, is often more attainable once a patient is pregnant. And so we're already kind of missing the boat at that point. So we really should be able to support the medications for opioid use disorder, or MOUD, treatment and availability for anyone of childbearing potential. And then we should really kind of avoid blame when it comes to public messaging. It should be more of a support in supporting people, not only kind of during, but also before and in between pregnancies. I think it would be helpful to keep track of access metrics to MOUD, and I think that would make it more central to the conversation rather than only focusing on, how did baby do, neonatal outcomes. And so access is going to require teamwork from more than just addiction medicine. It's going to include reproductive justice groups, our OBGYNs, MFMs, insurance, people with lived experience, and so many more. And so I think at the end of the day, by emphasizing this prevention, preconception, we can aim to encourage that those medications for opioid use treatment or opioid use disorders be started prior to pregnancy, as much as we emphasize them being used in pregnancy.
I really also like the idea of all of the different involved groups for this, that it's a public health messaging that doesn't need to come out just through the addiction community, but it really needs to be part of like overall healthcare and public health messaging more broadly. And so I think that's really important. But, we all agree here very clearly that the importance of medications for opioid use disorder is really paramount, and having access to them early on for prevention. Yet, what was interesting, I think, Dr. Wright, Tanner, in your surveillance data, was there was a little bit of a paradox. The MOUDs were actually documented more frequently in the pregnancy dyads with fentanyl exposure than those without. And, a little bit more, 81% versus about 73%. And so you have an interesting explanation for this. And I'm just curious if you can comment on why you think that's happening, and what does that mean for surveillance type data, and how we really need to be careful with the nuance for how we interpret these things.
Yeah, I think it's a lot of times you get in some of the analyses, you find some of these numbers and you're interested, you're curious as to why or what. I think we had a lot of discussion on this, and I think likely in our discussions, likely what that is reflecting is probably just a higher frequency of healthcare system interaction than true biologic mechanism, I think. Is kind of our again our assumption, right? That we think that that's what it's reflecting. So it's again in the surveillance network type of research, it's tough to really drive down and figure out where some of these analysis differences that we see are. But that's kind of like what we think is probably what's being reflected in those numbers. I think that across the discussion and across our priorities in regards to what we're doing from a surveillance network standpoint, we recognize that when you do a lot of this analysis and looking at some of the neonatal outcomes based on differences in MOUD, either timing or MOUD choice in pregnancy, I think the number one priority, the bottom line, is kind of constantly always the same, that what is the best treatment for the pregnant or parenting individual is going to be the best treatment overall. I always say I get the pleasure of getting the perspective of being the pediatrician and saying healthy and thriving parents are going to have the healthy and thriving kids. So I think that no matter what, in pregnancy or either in parenting, MOUD, the best MOUD that is for that patient is going to be the best for the pregnancy, the best for the neonate, the best for the child later on. And I think also in that same tone, in talking about differences in choice of MOUD and in talking about differences in timing of MOUD, the one thing that we look at often is that, when we always talk about whatever is right for the patient is going to be right for the pregnancy, is going to be right for the future neonate, the future child. And in doing that, we see that there's a ton of research going on around MOUD in pregnancy and in the postpartum or parenting period. And so I also think some of the things that we see as difficulties or nuances in how we treat opioid use disorder in pregnancy and parenting, I think that will also kind of change drastically in the next few years, not only from a science and clinical care basis, based on a lot of the publications that you guys put out within this journal itself, about how we should approach pregnancy in the postpartum period, but also think from a public health and from a policy standpoint in access to MOUD, specifically looking at methadone and how methadone is utilized now versus some of the potential that methadone may have if we're able to kind of liberate some of the red tape around the use of methadone.
Mm-hmm. Mm-hmm. Yeah, and I think in addition, when you look at the level of scrutiny that pregnant persons who are using medications for opioid use disorder get in our system, I wonder if there's a higher level of picking up on any abnormalities and I think, substance using pregnant persons also have a higher level of that, but I think there's a particular stigma for people who are using medications for opioid use disorder during pregnancy that may also be influencing what's getting picked up in the medical record, and that level of scrutiny might be reflected there. And then you can, to some extent, control for health service utilization and more contacts with the healthcare system and things like that in these big databases, but not entirely at the level of things like higher levels of stigma really influencing that. Marcela, I invite you to share some additional thoughts.
Yeah, I think that's a really important point about ascertainment bias in any of these studies, is that many pregnant people will, with the substance use disorder, will be able to achieve abstinence without medical intervention. So there are even people using fentanyl stop using, and there is a lot of disincentive to disclose that to your healthcare provider if you have stopped using, if it is under some control during the pregnancy. So we do also, looking forward, need to look at not just what is known codes for opioid use disorder, but if we're starting to see this cluster of signs in people who aren't identified as people who are using fentanyl, because there's a lot of disincentive. There's criminalization, there's referrals to CPS, there's stigma, there's bias. There's a lot of reasons why
people may not disclose that they've been using. And we see this in our clinical work all the time. And so I think it is important for us as researchers to think about what are there cases that aren't being ascertained because we're not seeing the researchers and clinicians aren't seeing the exposure because of the way that society has treated substance use disorders as very different than other medical conditions.
Yeah, well said. And so I just want to take this opportunity to thank everyone for joining us. So Dr. Marcela Smid, supporting editor for the Journal of Addiction Medicine and co-author with Dr. Tanner Wright for the Dorsey et al. Paper, and then Dr. Elizabeth Ljuba Mirsky joining us with her paper. It's a really interesting discussion about the importance of having these large surveillance models and what they can tell us, as well as these smaller case series that give us more of that detailed, granular information to really inform the science, that we need to be patient with the science so that we can not jump to a conclusion that may have potentially quite significant public health and stigma consequences associated with it, and that we think about some of the nuance around polysubstance exposure, the importance of having underlying biological plausibility and how that's important for understanding what we may or may not be seeing, as well as taking what we know so far to inform the importance of prevention and supporting things that we already know are good, like starting medications for, opioid use disorder as soon as we possibly can for anybody using, and in particular for people of reproductive potential. So with that, I think this was a great discussion. Really enjoyed talking with you all and appreciate you sharing your work. And I encourage people to look at the publications that are available in the Journal of Addiction Medicine about this.
And if you're out there, and last thing I'll say is, you're out there and you're thinking about publishing your case series, the Journal of Addiction Medicine is very interested in seeing those publications as we build the data for and against this.
Yes, absolutely. It's an important scientific discussion, and the Journal of Addiction Medicine would be a great home for continuing this important conversation from all these different angles.
Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.